What's the
Yes.
time? 10:04. Yeah. Good morning, dear members of AAPI. Thank you for joining on a Saturday morning. And we really have a distinguished panel of nephrologists speaking today to us, Dr. Rajiv Saran and Dr. Agarwal, and our distinguished moderator, Dr. Sharma, and our colleague and our CME chair, Dr. Srini Gangasani, will continue the proceedings from now. So please stay tuned, and we are expecting a fantastic CME program now. Thank you so much.
Thank you, Ravi. Thank you for the introduction. Hi, everyone. Good morning. This is in our series of webinars for this year. We have excellent speakers to talk about the kidney disease, kidney failure, and what we can do about it, Dr. Agarwal and Dr. Saran. And thank you, Dr. Sharma, who is instrumental in putting together this CME. He's also been helping us with the Global Health Summit in Vizag, and he has done a wonderful job. Thank you for joining this morning. So I want to introduce our moderator, Dr. Sharma Prabhakar, who is the professor and vice chair of Department of Medicine at Texas Tech University Health Sciences Center. He's also chair for our AAPI Academic Affairs and Scientific Research Committee. He's an excellent researcher and academician and has done a wonderful job helping me with the CME this year. And he'll be moderating the session and introducing the speakers, and have a wonderful CME this morning. Dr. Prabhakar Garu, take over. Thank you.
Thank you, Dr. Ravi Kolli Garu and Dr. Srini Gangasani Garu for those introductory remarks. And I thank everyone in the audience for joining this exciting session on in the early hours of Saturday morning. And it gives me a great honor and privilege to moderate this scientific session on kidney disease and kidney failure. We are in particular very fortunate to have two very highly accomplished nephrologists and eminent speakers. The two common renal clinical syndromes that we encounter both as primary providers and as specialists in the hospital setting, in the outpatient setting, are acute kidney injury and chronic kidney disease. And we have now two excellent speakers talking about these two specific topics. Each topic will be approximately 45 minutes, and this will be followed by a question and answer session for about 15 minutes for each talk. And I request all the audience who have questions to type those questions in the chat box at the bottom of this screen, and we'll try to answer as many questions as possible. And at the end of the conclusion of the webinar, I request Dr. Ravi Kolli to come back and give the concluding remarks, as well as Dr. Gangasani. So without any further ado, we'll start with the first speaker. I think since Dr. Saran is already ready with his slides, we'll start with him. Dr. Rajiv Saran is Florence Bingham Research Professor of Nephrology and a Professor of Medicine and Epidemiology at the University of Michigan. I've known Dr. Saran for a long time. He's also a past director of the United States Renal Data Systems, which is a nationwide registry of patients with end-stage renal disease. He has done extensive and excellent work in CKD epidemiology and surveillance. So today he's going to talk to us about chronic kidney disease, contemporary approaches to prevention and management. Dr. Saran, please take over.
Thank you, Sharma, for that very kind introduction. Very grateful to the organizers, specifically for your invitation, and delighted to be here amongst friends. Can you all see my slide, or?
No.
Yes. Okay.
We don't see your slide.
Yeah, the title is, it's a very academic title: Contemporary Prevention and Management of
Dr.
Chronic Kidney
Saran,
Disease.
we're not seeing your slides yet.
Oh, hang on.
Share screen button at the bottom, and yeah.
Do you see them?
Yes.
Okay. Great. So it's a pretty academic title, and I'm going to focus a lot on prevention. In fact, it could all be labeled prevention, because even treatment or management is a form of prevention. So the focus here will be just that. And I hope I give you some key messages in that regard. Not sure why my slide is not moving. I'm asking it to move, but it's not moving. So hang on.
Just press the enter button or right
Yeah, I'm doing all that.
arrow.
It's somehow not doing it.
PDF or is it
No, it's a actual PowerPoint slide. Yeah.
So
Hang on.
Rajiv, just try to put the arrow on the slide and just click it. And then your keyboard will allow you to advance the slides.
Yes. Okay, is it moving now?
No, we cannot see your slides now.
Okay, I could
Screen.
move them probably. Okay, let me just share my screen again.
Yeah.
A second, sorry about this.
Does the office have it? Or if you send it, I can be your assistant.
That would be another.
option. Dr. Agrawal, you want to, or if you have any?
I'm screen sharing now, it says.
Yeah, we can see your screen. Just do the slideshow.
Yeah, just, yeah,
Yes.
go to the, yeah. Now you can do it. Yeah, press that button there.
Yeah, I have it. Now, do you see my display setting as, you see the main screen now, or do you see both my next slide and that's my main question?
It's thinking.
Okay,
Yes,
because on my screen, I have two screens here on the left. I see on my main screen, I do see the main slide and the next slide, but on the bigger screen, I just see my
the entire screen, yeah, deck. Yeah.
Are you able to see the slide?
Yeah, it is circling the window.
Oh,
For some reason.
are others able to see the slides?
Nope. I can see the slide, but it's going in circles. It's not in the slide presentation mode, Rajiv. So
It is on my screens, so not sure why.
Because you have two screens, only one is being shared, I guess. And
what are you seeing? Or you're not seeing anything, or?
we're seeing the PowerPoint full deck.
Yeah.
Yeah, the full deck of your PowerPoint with on the ribbon side, on the left side, the slides.
Now do you see it?
Yeah, we see now.
There we go.
Now we can.
Now it's fine. Okay.
Yeah.
All right. Without much further ado,
Yep.
We go.
Everything.
my only disclosure slide is that I still run the CDC's kidney disease surveillance system. We've renamed it to be the kidney disease surveillance system as opposed to chronic kidney disease surveillance system. This is a system that runs parallel to the United States renal data system that focuses almost entirely, if not about 80%, I guess, 80 to 90% on end-stage kidney disease. The CDC's kidney disease surveillance system is less known, but we have recently updated the website, and I just show you the front screen of that just to make people aware that tracking and preventing kidney disease in America is a new or relatively new project that has recently been activated. The new website has been activated, and it surveils all stages of kidney disease, and we hope to expand it progressively over the next year or two so that it's a full system, a fully functional system. I wanted to show this initial slide because we don't exist in a vacuum. We are mostly here in the downstream of healthcare and addressing individuals' healthcare needs. But we have to keep in mind, and I would urge practitioners in this audience, mostly I think they are MDs, to keep this picture in mind, the analogy with the flowing river, where the downstream is where we see trying to rescue people here at the end of the spectrum. But it's very, very important to go upstream, addressing individuals' social needs, as well as further upstream, perhaps thinking about partnering with public health and preventive strategies, and in fact, addressing certain community conditions, so surrounding the practitioner's clinic or hospital system or outpatient service. Think of partnerships beyond just the downstream healthcare, because that's what we all obsess about. That's what we spend most of our daily lives. But it's very important to keep this overall the parable of the river, flowing river, where we are only rescuing people downstream. And therefore, I think one of the key facets of my talk will be emphasizing that the major drivers of disparities in health are in fact the social determinants of health, which are very, very upstream. It's about communities, it's about education, access, quality of care, access to quality care, education, economic stability, community context and neighborhoods, the built environments, and of course, healthcare access and quality is of great importance to us. It has been estimated by several now that clinical care accounts for only 20% of a county level's variation in health, and the social determinants of health upstream account for as much as 50% and are the major drivers of health disparities. And therefore, it goes without saying that coordination across sectors, including governments, community-based organizations, others, it is a big business of many sectors coming together. It's not just about the doctor and the patient, although bulk of my talk will be about that issue. I want to define surveillance because I think surveillance in any form, whether it's your clinic, patients, surveilling them, or whether it's your health system, in quality improvement programs, or whether it's the county or state or nation, disease surveillance is very fundamental. Unless you know all your patients' conditions, that one patient in particular, you may treat them, but if it's not in the context of what's going on in the clinic, I think it's important to keep in mind. And there is a definition, there's a classic definition of surveillance, ongoing collection of data, interpretation of this data, and then planning what to do next. So a systems thinking ought to be brought in to the fold. I think increasingly that's becoming very, very important. The weakest link in surveillance, I think, is this linking to practice. So how you collect, analyze data, et cetera. But unless you disseminate and then implement change, it's not of great use. And this concept has recently been placed on steroids, as it were, because of the availability of big data from multiple sources, and is being called the learning health system in the setting of a health system, of course, but essentially it's very, very analogous and almost identical in concept and principle to surveillance. And at the center of it, of course, is the health problem of interest. Here it's kidney disease, but the formation of the stakeholder group, a learning community of practice, if you like. So collecting data and the practice itself, generating data, the data being analyzed, then interpreted, contributing to knowledge, and designing interventions as you go along is the essence of high quality improvement programs. And the two are very analogous, and I won't dwell on this anymore, but these disease surveillance systems or quality improvement programs, if you like, or learning health systems should be dynamic. They should not be static, wait for publications, wait for the reports. That's the old paradigm. I think it should increasingly be more improvements and iterative improvements in real time. So where does kidney disease stand? Just to give you a big picture context, it's now one of the 7 major NCDs, non-communicable diseases recognized by the CDC. Chronic diseases is the big problem, and kidney disease falls is the key, is no longer the Cinderella of chronic diseases, because for a long time it was neglected. It was not in this portfolio of chronic diseases. And the CDC, I think, was one of the earliest to recognize the fact. And here's the placard showing kidney disease at the bottom right. There's heart disease, cancer, big ones, chronic lung disease, stroke, Alzheimer's disease. And many of them, especially diabetes, are the forerunner, if you like, of most chronic kidney disease, but not exclusively. So a lot of patients who are non-diabetic can have kidney disease from a variety of other conditions. So just to put it in context, 6 in 10 adults in the US have a chronic disease. 4 in 10 have 2 or more chronic diseases. And this is the leading cause of death and disability, not only in this country, but around the world. Every region, every part of the world, the non-communicable diseases are the big problem. And of course, COVID distracted us, consumed us in the last 3-4 years, but it's we're very grateful that that's past. hopefully past and not recurring. But again, in that context also, it was the people with chronic diseases that suffered the most, had the most acute complications. And so I think unless we deal with the fundamentals of healthcare and chronic diseases in general, we're not going to make dents in any specific area. So coming to kidney disease, which is the main topic of today's talk, the definition, I think most of you must be familiar. The definition has been around since 2002, or when the KDOKI program came out with the Kidney Disease Quality Improvement Initiative from the National Kidney Foundation, came out with this definition that CKD is a persistent abnormality of either structure or function in the kidney, and chronicity was defined on the basis of 3 months and must have some implications for health if, for example, if the GFR or the glomerular filtration rate is under 60, and this dial on the right side is something we use in the clinic here at Michigan to educate patients about GFR, and it shows the green zone, which is supposedly normal in the setting of, or questionable. It could be stage 1 or stage 2 kidney disease if there's evidence of kidney damage, albuminuria in the main, and a urine albumin to creatinine ratio of greater than 30 milligrams per gram of creatinine. But most of the kidney disease that certainly we see in the clinic or the primary care physicians see in their clinics are when GFR tends to drop below 60, although that's also pretty late in the game. A lot happens between a normal person's GFR on average being around 100 or 80 in some communities, especially in India, the so-called normal eGFR may be closer to 80 or 90 and not 120. 120 would actually be the limit for hyperfiltration. Between 60 and 45 would be 3A. 3B would be less than 45 to 30. Stage 4 would be 30 and less than 30, but higher than 15. Once eGFR drops below 15, and the formulae get more and more accurate as the GFR is dropping, the eGFR standard CKD AAPI equation gets to be more accurate. In fact, any equation, the lower the GFR, the more accurate prediction has been observed. But eGFR, practically speaking, eGFR of 60 or less, stage 3 or higher, and presence of albuminuria defines most chronic kidney disease, but it can be with either one of those two abnormalities. And of course, this is that classic iceberg. Most of us have been obsessing for a long time on a stage 5 and kidney failure and end-stage kidney disease, but that's really the tip of the iceberg. There's a lot of stage 4 in epidemiological terms. It's about the same as the stage 5. So there's a lot of stage 5 people in the nation. Stage 3B, 3A, these are the lower stages. I guess most of the times patients come to the care of nephrologists in either late stage 3B or 4. Stage 3A and stages 1 and 2 are mostly the purview of primary care physicians unless they develop complications such as acute kidney injury or heavier proteinuria or changing the course of their disease rapidly. So the main point I'm going to make is, in subsequent slides also, is that earlier screening is there's more and more evidence that earlier screening is beneficial. In fact, there's now been a lot of advocacy and data gathered and so on that the US Preventive Task Force Services, that during their last update about CKD screening in 2012, did not think that chronic kidney disease was worth screening for in the general population. And that was the end of it. They have not updated their guidelines, and it is hoped that in recent times, I think last year, there were moves to promote or improve the advocacy towards US Preventive Task Force Services to make screening a more important paradigm in the setting of suspected chronic kidney disease, especially those with risk factors. I think my definition of chronic kidney disease is the simpler one. And now I think it's mandatory that we think about chronic kidney disease in a slightly more sophisticated way. I don't think this is the end of the pathway yet. It's going to get more complicated over time, just like in cancer world. But albuminuria, this is the now dual classification, or if you like, and based on prognosis among people who have any degree of albuminuria as a continuous function as you related to outcomes. So on the right side here, this is a heat map showing different categories of albuminuria, normal to mildly increased, which is A1, moderately increased, which is the traditional misnomer of calling it microalbuminuria, which is no longer a term that's no longer utilized, and then severely increased albuminuria above 300 milligrams per deciliter per gram of creatinine, sorry. And then G1 through G5 are the stages of eGFR categorization that people are more familiar with the 3A and 3B stages being introduced in around 2012, modification of the previous classification that was simply 1 through 5. And the red areas are where there's very high risk of complications and progression to end-stage kidney disease and cardiovascular disease events. The yellow is the moderately increased risk. The green is little to no risk. And so you can actually risk stratify your patients if you dually test them both by using a serum creatinine to estimate eGFR and more cystatin C, which is another marker of kidney function that's now recommended to be used for more accurate prediction of kidney function. But remember this prognostic classification, which was introduced in 2013. And if you suspect kidney disease, please do both evaluations, not just one or the other. So more than approximately at least 40 million US adults are estimated to have chronic kidney disease. These are data based on the National Health and Nutrition Examinations Survey, which is conducted by the CDC in 2 yearly cycles. This is the traditional method of surveillance, which is very labor intensive, quite inefficient, not geographically representative. Nevertheless, cross-sectionally, 2 years worth of data gives you fairly robust estimates that are weighted to the general population, composition of the general population, and they oversample certain groups like Hispanics and African Americans to be more representative of the nation. But it cannot tell you what the prevalence of kidney disease is in, say, in one of the states or in a county. You have to just assume that it's nationally representative. So more than 1 in 7 US adults over the age of 20 or greater have kidney disease. That's a huge prevalence. 15% of US adults estimated to have chronic kidney disease stages 1 through 5. Actually, this sample is not very good for stage 5 kidney disease. And even for stage 4, the sample size is pretty small. And among diabetics, which is shown in the yellow box here, approximately 1 in 3, somewhere between 30 and 40%, depending on the duration of diabetes. Type 1 diabetes, especially, is more clearly studied in terms of its long-term natural history. But in type 2, we, at least 40 to 50% patients can go on to develop kidney disease in some shape or form, especially if their risk factors are not controlled, particularly hypertension. Another important facet of kidney disease, in this case, this slide is showing the standardized incidence rate of end-stage kidney disease by health service area in the United States. And the main reason why I'm showing this slide is to show you that the incidence rates of end-stage kidney disease and with implications of chronic kidney disease in those areas, there are many hot spots. And the incidence rates in some of these areas is as high as 500 per million population per annum, which is comparable to many developing nations. So there are hotspots, especially in the southern half of the United States, counties along the Mississippi, and the state of Virginia here, Ohio, Mississippi Valley, and some pockets in the southeastern part of the United States. But the Sun Belt, so-called Sun Belt, and then there's the western, eastern parts of California and in some of the counties there, but very, very high incidence of end-stage kidney disease. And many of them are not from known causes and could be misclassified as chronic kidney disease of diabetic etiology or unknown etiology, but it's not clear why there's such a high incidence. Most of it is primarily, I think, in accompaniment with diabetes and hypertension, and some of the minorities that are high density of poverty and minority populations that are disadvantaged, that have experienced historically racism and discrimination. They tend to have the highest incidence of chronic diseases in general and kidney disease in particular. We did some analyses as the USRDS Coordinating Center a few years ago and showed that we studied the lifetime incidence or the lifetime risk. So we converted incidence rates to lifetime risk of end-stage kidney disease, which is another way of thinking of incidence rates, and showed that on average, if you look at men in the if you're born male in the United States, your lifetime risk on average is about 4%. And it's the highest among African Americans, followed by Hispanic population, and then the non-Hispanic Asian Pacific Islanders. And the lowest, of course, is in the non-Hispanic white population. The risk is much lower. It's more than twice as high, almost 3 times in some cases among African Americans. And on the right side is the chart for females. And it's very similar in pattern, although the overall risk of end-stage kidney disease is lower among females. But the pattern is very similar. One of the major events in 2021, 2021 and 2020 during the pandemic time was this major shift to a non-race-based EGFR estimation. And both the ASN and National Kidney Foundation got together based on a lot of activism in the community to try and get rid of race as a coefficient in the EGFR CKD AAPI equation. And this was developed mostly as an effort to reduce race-based medicine, as it was called. And certainly the implication of this was that that we would have to stop using this coefficient. There was a lot of back and forth, a lot of editorials, very little in view of hard evidence of this change in paradigm. But eventually, I think based on consensus, an agreement was reached that race should not be a coefficient or not be used as a coefficient in the EGFR formula. And they finally came up with a mathematical derivation using existing data of measured versus estimated EGFR of an equation where the race coefficient could be discarded. With the result, the overall GFR for Black participants from all those studies was going to be lower, a little bit lower. For white non-Hispanic populations, the EGFR estimates were going to be slightly higher. And these graphs, and this could be the subject of an entire 1-hour talk, but the overall estimated EGFR in Blacks was lowered slightly, and in white population was commensurately higher. So the mean or the average EGFR is about the same. And the implications of this is that the incidence or the prevalence actually of CKD would be higher among Black participants. And we have done some work showing how much higher and so on. Prior to this formula having been implemented across health systems, this has increasingly been taken up. I think nearly 80% of health systems now in the US have dropped, the labs have dropped the race coefficient in reporting their EGFR estimates. And this has kind of come to stay. And from surveillance standpoint, I think overall, the prevalence of CKD will drop from 15% to around 12% when we do this. We have not implemented that in surveillance yet, in the surveillance project yet. I think we are required to do it based on the community's acceptance of this formula. And so the prevalence will be somewhat lower in future iterations of kidney disease surveillance. So these are the recommendations made by the NKF ASN task force in 2021, end of 2021. So for US adults, immediate implementation of the CKD AAPI creatinine equation refit. It's a refitted equation without the race variable by all US laboratories. National efforts to facilitate increased and routine and timely use of cystatin C, which as a developed country, the USA can afford to do, even though it's quite expensive for developing countries as yet for universal implementation. But I think more and more cystatin C use will be seen for confirmation of eGFR in adults who are at risk of CKD. And lastly, research, of course, they left it open that research on GFR estimation with perhaps new markers, endogenous filtration markers, and there's a lot of work going on in this area by several groups in this country to develop new tubular as well as other markers of function. I think one of the concepts now being floated is that it's not all about GFR, that you got to take the other big compartment, which is the tubular-interstitial compartment, into account in estimating or in coming up with an idea of what the kidneys are doing. So this is the traditional conceptual model of CKD progression. And in the clinic, I guess this was developed by Andy Levy and his group back in 2000, early 2000s, that which sort of shows you patients at risk on the left in green, those with some kidney damage. So here there is no kidney disease, but person is at risk. So the paradigm is to screen them. Once there is early evidence of kidney damage or late evidence of kidney damage, and you got to obviously make a diagnosis, treat to try and slow its progression. Some people are more prone to progression than others, and you can predict by using some prediction equations these days. 4 variable, the kidney failure risk equation, for example, has been touted as being a popular one, has been implemented by some health systems. You estimate progression as you manage these patients and eventually prepare them for, if it seems inevitable, for kidney failure, for renal replacement therapy by dialysis or transplantation, or no treatment if some patients choose to go that route. Otherwise, mortality is the rule in this instance, and all kinds of management, both lifestyle and medications, and avoiding nephrotoxins. So this conceptual model is useful in the clinic, I think, for managing patients, remembering this in terms of when to intervene, when to refer, and so on. The guidelines are pretty explicit about stage 4 being a time when you would refer to a nephrologist and so on. One of the questions that I've often been asked by lay audiences or patients or physicians who don't actually see many kidney, why measure urine albumin? And this is a message we are trying to give in quality improvement programs here in Michigan. There's a kidney disease quality improvement program going on in the context of diabetic kidney disease. And when we talk to providers and clinics and advanced patient care providers, and not just physicians, we try to give them why albumin is an important marker of, or relatively early marker, not most early marker, but relatively early marker of damage to the filtration barrier or compromise of the filtration barrier in the kidney. And any detection of albumin is not supposed to be there, and is one of the early signs of kidney disease. And also because albuminuria is now part of the diagnostic criteria for kidney disease and has implications for prognosis. Remembering this heat map on the right that I showed you earlier, and increasing albuminuria is a continuous function indicator of a predictor of kidney disease progression, risk for acute kidney injury, cardiovascular disease, and all-cause mortality, in addition to end-stage kidney disease. So I think as nephrologists, we tend to think of end-stage kidney disease as the major outcome. In fact, it's a rare outcome among people with kidney disease. The more common outcomes being cardiovascular disease. The most common cause of death in those with kidney disease is cardiovascular disease. Acute kidney injury, these people are much higher risk that can then go on to progression or recover, et cetera. And that's a topic for the next lecture. But it's also a target for therapy. So you can titrate responses to albuminuria over time and we track the semi-quantitative or quantitatively the albumin excretion in the urine using urine albumin to creatinine ratio. And here is a chart showing how to interpret this and the normal, the modern terminology and discarding the old terms of micro and macroalbuminuria and these typical ranges of small amounts of albumin, moderate amounts of albumin in the urine, and large amounts of albumin in the urine. And this corresponds roughly to a dipstick equivalence for proteinuria and or albuminuria. But again, one is encouraged in the clinic to order an albumin to creatinine ratio done in a lab. Here is an example where you can change trajectory of kidney disease or in a population-based model. And I show this as an example because the USRDS first pointed out that Native American adults have the highest incidence of diabetes-related kidney disease compared to whites, Asian Americans, or Hispanics, or even Blacks. And more recently, we've shown that a small population that goes under the radar, the Native Hawaiian and Pacific Islander populations that have experienced long trajectory of historically of discrimination and racism, they have actually the highest. They have even higher than Blacks. The incidence rates of end-stage kidney disease, mostly due to diabetes, are much higher in that specific population. That's not even shown on this graph, and often is merged with Asian. They are quite a distinct category, and Asian Americans, in fact, have a lower incidence. Those living in the US have a lower incidence of end-stage kidney disease compared to the Black and Hispanic or Latino population. This program that was initiated by the Indian Health Service, and the graphic on the right side in the green bar, if you focus on the green bar, which represents the Native American, American Indian or Alaskan Native population in the US, the incidence of end-stage kidney disease came down fairly sharply over a period of about a decade. And this was touted as a success of, first of all, surveillance that pointed this out, and then quality improvement programs developed by the Indian Health Service with a lot of help from the NIH and the CDC to implement programs in place that over time led to a reduction in, this has not been replicated in other populations, although if you notice, even in the Black population, the bar in blue, the incidence rates have been coming down, and that's quite heartening to note. This was the exact model for diabetes care that was implemented across the Indian Health Service. And so this is just giving an example of a 58-year-old person, Joe, with diabetes and kidney disease, who has uncontrolled diabetes, and he has missed his doctor's appointments. And the care manager calls him for all that. Care managers were increased in number during this time of implementation of this program. But Joe says, I have no sick leave. I have no transportation to make to the appointments and or to pick up my medicines. And then the nurse is sent to his home to assess his home situation, check his medicines, check his blood pressure. And then he's connected with community and transportation resources. A clinic visit is scheduled for his next day off. And then at the clinic, of course, he meets the doctor, the nutritionist, diabetes educator, and so on. Pharmacist helps make sure that he gets his medication. So involving the different disciplines over time, his blood pressure and blood sugars are controlled, and kidney function then remains relatively stable. So this is an example where a public health and population health care management approach in the clinic led to great success, and of course, team-based patient care, which is more talked about than actually implemented in many parts of the US. Okay, why isn't my slide moving now? Stop moving for some reason. All right. any way you can move the slides from there, or should I just, I don't know what happened. Maybe it's my internet or something. I will stop share for a second and share it again. Do you see my screen now?
Yeah, we do
Yep.
see it in the pointer too, but are
But
the
it's
slides
not moving. Okay, I'm sorry about this. I don't know what is happening at my end.
Dr. Saran, if you want, you can send it to AAPI office email or one of us, then we'll send it to AAPI office. We can move it in while you're working on it. But I think whatever you did before, maybe let's try that again.
I'll send you the email of the AAPI office,
Okay.
or you can send it to us too.
Yeah, I'm trying to come out of the screen. Now, do you
Now-
see the change? Okay, it has
Yeah, I
started to
think, yeah, it
move.
is working now.
I'm not
It's
sure what
working.
happens. Yeah.
It's working.
So these were the things that were changed between 1997 and 2013 in the Indian Health Service. Diabetes clinical teams increased from about 30% to 96. Registries, utilization of patient registries went up dramatically, 39% to 93% nutrition services, access to physical activity specialists, culturally tailored education materials, and which was then actually taken up by this, the clinical practice guidelines for diabetes self-management and education programs published in endocrinology journal. This is a self-structured self-management program for diabetes and management, which is very, very similar to what was done, a structured self-management educational program, reducing risk, better management of complications, lifestyle changes, patient motivation, self-management and self-motivation practices, improving the emotional and mental well-being and treatment satisfaction and quality of life. Efforts were made to improve their life satisfaction scores and well-being. I don't know if they use therapists or others or just a social worker, but it resulted in improving diabetes-related knowledge, beliefs, and skills. They focused on vascular risk factors, and the recommendation was made by the diabetes program here that healthcare system should consider implementing a structured management program, self-management program for patients with diabetes and CKD, taking into consideration their local context, cultures, and availability of resources. Summary of that. So again, I just remind you that they were following this structure, but also implementing programs that are beyond this conceptual model here. So what about diabetic kidney disease? I think a lot of focus, half the end-stage kidney disease in this country is from diabetic kidney disease. And the good news actually is, and we've looked at this in NHANES too, that there is a decrease among CKD patients of diabetes complications, specifically chronic kidney disease, from around 44% chronic kidney disease in diabetics in the NHANES data, dropping down to 36%. And it's sort of plateaued right now. It's not continuing to drop, but there is overall a drop in diabetic complications. Maybe this is from the emphasis on glycemic control, ACE and ARB use, but our data doesn't prove that. It is only observational. The bad news, of course, as I mentioned, is it continues to remain the most common cause of end-stage kidney disease in the US. And there may be other risk factors at play. Obesity is rising, prediabetes is rising across the country, and these are also independent risk factors for chronic kidney disease. So incident cases in 2016, of course, nearly half, and that continues to remain the case. That has not been reduced. There's a long history. There's been huge developments in the diabetes world for anti-diabetic drugs that may be part of the reason why glycemic control is better. And the most recent ones, of course, the SGLT2 inhibitors, the first one being canagliflozin, that was introduced in 2013, and then several have been introduced since that time. There's now around about 11 classes of drugs in diabetes. The kidney disease world is somewhat behind, although we are rapidly catching up, I'm pleased to say. And so I'm going to focus the few more minutes on these newer drugs, particularly talk about the SGLT, the sodium glucose receptor inhibitors in the proximal convoluted tubule, the SGLT2 inhibitors for diabetic and non-diabetic chronic kidney disease now. So the mechanisms of action are in the proximal convoluted tubule. These inhibitors, of which canagliflozin was the first one to be approved, they decrease glucose reabsorption and increase its excretion. Basically, that's the mode of action. This slide tries to show you the glomerulotubular feedback loops and the role of adenosine in vasodilatation. Adenosine activation leads to vasodilatation of the afferent arteriole. When you give SGLT2 inhibitors, the effects are shown on the right side in this figure. The intraglomerular pressures are lowered, the afferent arteriole, there's more activation of the adenosine receptor, and eventually, and so there's afferent arteriolar constriction. It restores the glomerular pressure and flow more towards normal, but it does increase the distal delivery of both glucose and sodium, which is in fact the sodium delivery to the distal tubule actually helps the macula densa to then do this tubulo-glomerular feedback to reduce the pressure in the glomerulus. So this is touted to be the main mechanism of action in reducing the glucose and glycemic control, but also the intraglomerular pressure. And the other mechanisms of action are less understood, but it's supposed to increase glucose, insulin sensitivity, etc. There are other benefits too. So the clinical trials, which I'm going to run through some of the key ones in the next few slides, all show significant risk reduction for both cardiovascular outcomes as well as renal outcomes. So here's the EMPA-REG study, which all of these, I mean, it's remarkable. Close to 10,000 patients, 8,000 patients, 4,000 patients, large clinical multi-center international studies being done comparing and patients being on standard therapy with statins and ACE and ARBs. In this case, the primary outcome was a composite of cardiovascular death, MIs, and CVA. The benefits persisted in the CKD subgroup. So this was a post hoc analysis, and it showed that the proportion of compared with placebo in one arm, which doesn't mean they were not on anything, they were on all the standard therapies, but for the drug comparison, they used a placebo medication. But the EMPA group, the empagliflozin group, showed significant reduction in events, the primary outcomes and the secondary outcomes. The CKD subgroup showed what was apparently an even bigger risk reduction of about 30%. Another study called the Canvas, also a very large study, 10,000 people at start, and they looked at progression of albuminuria on the left here, and the other one was the 40% reduction in GFR as one of the outcomes, or requirement of as a composite outcome, or kidney replacement therapy, or death. And remarkable risk reductions. Here is 40% risk reduction. Here's about 27% risk reduction of progression of even albuminuria. Numbers drop towards the end, but still statistically very sound and clinically relevant results. More recently, I think the studies are increasingly showing benefits in non-diabetics. So this is the DAPA CKD trial, a randomized control trial of over 4,000 patients, DAPA versus placebo in patients with CKD with or without diabetes. And 1,300 or 1,400 had diabetes. There was high risk group with albuminuria. eGFR range was wider, so they went as low as 25 to 75 plus albuminuria. And majority of the patients were on standard therapies with statins and ACE inhibitors and angiotensin receptor blockers. The primary outcome, a composite of 50% decrease in eGFR, end-stage kidney disease, or death from a renal or cardiovascular cause, shown here on the right. And big risk reductions here, relative risk reductions. I think when I look at the data, it's the absolute risk reductions are somewhat less impressive, but there's no doubt that there was benefit here. and it continued for long periods of follow-up. So very, very powerful data. The EMPA kidneys are another one, a randomized control trial of well over 6,500 patients. Empagliflozin in both diabetics and non-diabetics, again showing remarkably consistent findings, very recently published in the New England Journal just last year, late last year. And this particular trial actually showed benefits in the subgroup analysis. So even in the non-diabetics, there was significant risk reduction, close to 20%. In those with very low GFRs, less than 30 ml per minute, also the risk reduction persisted. So no room for the therapeutic nihilism. In those with low levels of albuminuria, also the result was consistent. So clear, are they for everyone? There's uncertain benefit in non-diabetic CKD without albuminuria. I think that's the only category where we are still uncertain. In all other categories of kidney disease, I think they're very relevant. I'm going to skip that slide. There's some reduction in GFR at the outset, but over time, the kidney function is relatively well preserved. And these slides segments are just showing that phenomenon where those treated with these drugs tend to remain stable, and then over time, their GFR is better preserved compared to the control group. Clearly, the team is important, and everybody involved, including primary care, of course, which the bulk of the diabetics are treated, and those with stage 3A and B kidney disease, but specialists like endocrinologists, cardiologists, nephrologists, all have to work together. It's no one person's or one team's responsibility. And the earlier the intervention, the greater the overall impact, thereby highlighting the importance of screening people early where they have risk factors. For albuminuria, it's a simple test, easy to order, and specialist involvement often comes later stages of kidney disease. There's another class of medications that's now arisen to the occasion, selective mineralocorticoid receptor antagonist for diabetic kidney disease. I'll skip the background. Spironolactone and eplerenone are the previous variants of this, but the most recent ones are the non-steroidal selective aldosterone receptor blockers, finerenone. This is a trial, the Fidelio trial, which was published recently by Dr. Bacris, New England Journal publication in 2020. Again, showing in patients with type 2 diabetes, with compromised eGFR and albuminuria, receiving ACE and ARB therapies with a baseline potassium of 4.8, significant reductions in the primary outcome of end-stage kidney disease and eGFR reduction of 40%, very convincing, but smaller in magnitude, I would add, to the SGLT2, and slight elevations in potassium, although not to dangerous levels in the lower graphic here. So again, another agent in the armamentarium. There's some key differences between finerenone, which is shown in the right third bar here. It's more expensive, of course, and the effect on blood pressure lowering is less compared with the older ones. And I think that needs to be studied further, whether it has longer term benefits compared to the cheaper alternatives of eplerenone and spironolactone. I think that evidence is still not out there, but it has been incorporated into the ADA and KDIGO, the American Diabetes and the Kidney Disease Improving Global Outcomes recommendations. And they're recommending non-steroidal MRAs for patients with type 2 diabetes and eGFR of greater than or equal to 25 with normal serum potassium and albuminuria greater than 30. So below 30 albuminuria, still the jury's out there. But I was very heartened to note that the latest KDIGO 22 clinical practice guidelines, synopsis of which is published recently in the Annals of Internal Medicine, that there's a lot of emphasis on the baseline lifestyle modification, and that forms the foundation of all management. The drugs are important, I think, and have to be individualized with, and more people need to be placed on these drugs, but don't forget the fundamentals of diet, exercise, smoking cessation, weight management, and involving ancillary teammates in partnering with ancillary services. And then the metformin, SGLT2 inhibitors, RAS blockade, and statins are the first line. GLP-1, which I've not taken you through, antiplatelet therapies for those that have had atherosclerotic cardiovascular disease events, and the non-steroidal MRAs, which are just our additional drugs. They're the second line drugs. And then, but continue risk factor management every 3 to 6 months, reassess what's happening, talk to your patients, talk to their family, and connect them with social workers, dietitians, and possible other ancillary services. So in summary, CKD and its risk factors are very common in the general population, especially affecting disadvantaged populations. And early identification, I think, is an equity imperative. The newer drugs are great, and finerenone is another option. But testing for albuminuria, I think if there's one message, we need to check people more for presence or absence of albuminuria, which is such a strong predictor of outcomes, helps in risk stratification of those with or without diabetes as their underlying cause of kidney disease. And I would really urge people to think upstream, not just fixing it when it's down here at the waterfall and people are drowning and there's not much hope, but upstream, more and more upstream, fix the bridges, fix the infrastructure, fix social determinants of health. I think that's the main message. And I thank you all for your attention. I apologize for the interruptions due to the internet issue.
So, Dr. Saran, that was an excellent, insightful presentation. And there are over 120 participants in this group now.
Yeah.
I'm still waiting for more questions. There are just a couple. I want to start with one question. I mean, it's something that I want you to address with the general providers. You briefly touched on the fact that, the patients with CKD have to be referred to the nephrologist at some point. And maybe you can start by saying at what stage. But I also want to bring up that nationwide, up to 20% of the patients show up in end stage in ERs and, are, required to put on dialysis without any proper pre-dialysis care. So the point I want you to address is, what is the impact of pre-dialysis care on the outcomes of these patients? In other words, this is the question that a lot of providers ask. Why should we refer the patient to a nephrologist? What will they do differently? Because we are already managing their hypertension and diabetes and other things.
Yeah, I think in general, the publications suggest, many publications, I think over 10 at least that I know of, and including our own, has shown time and time again that pre-ESRD care, even the downstream, before the waterfall, people drop into the waterfall of end-stage kidney disease, even their pre-ESRD care helps to reduce bad outcomes when they go on dialysis or receive a transplant. So that association has been repeatedly shown. Increasingly, there's evidence that the earlier you detect kidney disease and you treat them with now modern medications, that you slow kidney disease progression, that in good hands with multidisciplinary care, appropriate referrals to specialists at optimal intervals that has to be individualized. There are some guidelines about less, at least 3B, late 3B, stage 4, absolutely, yes, you should consult, but you're free to consult nephrology at any time, even if it's a one-time consultation. I think they are important also to risk stratify. I think it's very important. That is a new paradigm. I think it's only introduced in 2012, 2013, the KDIGO guidelines. And this heat map that I showed, if one actually does this in practice, and there are no clinical trials of doing this versus not doing this, et cetera, but I think that would move the needle in favor of our patients who many of whom will not reach end-stage kidney disease, or if they do, they'll reach there in a better condition so that their outcomes as end-stage kidney disease patients will also be better. But I think we would urge people to check early, even when their GFR is normal, especially if they have risk factors, screen them for albuminuria, and then look to see where they stand in that heat map based on a dual assessment with GFR estimates, whether you do it by serum creatinine, whether you do it by the old formula, the new formula. I think it's less important. It's more important to make an assessment and but risk stratify them using albuminuria, family history, and so on, and manage them, cooperatively manage them with your nephrologist as and when you feel uncomfortable in managing them. And there can be other reasons, electrolyte imbalance, bone disease, anemia. There are other complications that can be managed that may have implications that I didn't have the time to go into. CKD management is a complicated affair, but requires multidisciplinary care. And it's, yeah, so I hope I've answered that part.
Yeah.
And the second question was related to end-stage kidney disease and pre-ESRD care, which is like a pre-terminal care almost for those that don't get a transplant.
So there is a question about from Dr. Sudhakar Jonalagada about coffee and CKD. You know, is it safe for kidneys? Drinking coffee is, and does it have an impact on CKD?
There's no contraindication for coffee and CKD. So far, I'm not aware of. If one has a heart condition or pro-arrhythmogenic potential, you should watch out. But in general, coffee is, at least there's no evidence, guidelines talk about avoiding coffee. But don't forget the water, don't forget the fluid intake in general. And hydration, I think, is important, not excessively, but maintaining hydration consciously is an important, especially in hot climates, and heat-related kidney injury is now well described.
Thank you. There's another question from Dr. Lalit Kalra. What are your opinions on high protein diet and kidney? Recently, more and more people shifting to protein only or no carb diet for rapid weight loss. How does it affect kidney function?
That's a great question. I think so. When we advise lifestyle modification to people who have definite evidence of kidney disease, we would ask them to avoid high protein diets. We would not ask them to take low protein diets unless, you know, they can moderate protein intake, a balanced diet, even Mediterranean diets. Mediterranean diet is touted to be one of the best diets out there, including for those with kidney disease. You do watch out for hyperkalemia in the monitoring, but it's very low risk of hyperkalemia unless they are on other drugs or other reasons for being hyperkalemic. That apart, I think, but prescribing high protein diets would not be advisable. I don't think there is evidence, both basic science as well as clinical, that certainly a modest protein intake is sufficient, and high protein diets may be detrimental in allowing more faster progression. Plant-based diets there's more and more evidence coming out about plant-based diets and Mediterranean diet in general. Of course, sodium restriction is very important in those with kidney disease and even others for management of hypertension.
Thank you. And then there is another question about SGLT2 and surgery. In other words, patients undergoing surgery. Do we need to stop on all patients or only patients who can't take PO fluids?
I think short-term stoppage of any drug is not necessarily bad, but I don't know of any recommendations in this regard. They are certainly contraindicated if you have type 1 diabetes, so shouldn't be used in that setting. Prior to surgery, stop. What was the question? What was the question for? Why should you stop taking them? Should you stop taking them before surgery? I'm not aware of any recommendations in that regard.
I think because of the fluid, not to drink the water.
Oh, I see. So
because of NPO.
right.
NPO.
So if the patients are overtly hypovolemic, I don't think there's an active consideration for them to come off their SGLT2 inhibitors. For that reason, watching their hydration status and taking them into surgery in a reasonably hydrated state would be fine. And glycemic control, of course, is important around the time of surgery, which will help.
I think the question was in general. They said drink any water like 7 hours, 8 hours before. So if you're eating it in the morning before surgery, do you recommend it stopping or That's what I think. That's
Right. So the glycosuria results in somewhat of a tendency towards hypovolemia, but overt hypovolemia, I mean, they should be closely examined. I don't believe there are strong recommendations. If you do it, I don't think it's harmful for 1 or 2 days if you skip SGLT2 inhibitor just prior to surgery. But there's currently no formal guidelines that I'm aware of. If you are, please speak up. And these may be individual practice variations going on. Yeah.
So there is another question about use of these SGLT2 drugs in non-albumin proteinuric conditions. Is
There's not evidence. There's not evidence yet because the trials didn't specifically excluded people without albuminuria but any albuminuria, it's helpful. I mean, it's been shown that even people that have less than 30 or at least 30 to 300, there's no doubt. But even with some albuminuria, they tend to benefit from SGLT2 inhibitors. But if somebody asks me, is there hard evidence that in non-diabetic kidney disease without albuminuria, is it helpful? I'd say there's not proven evidence. If they're diabetic and they're being treated on SGLT2 inhibitors, it doesn't matter that that's an indication. They have cardiovascular disease, that would be another indication for use of SGLT2, and I wouldn't worry about the albuminuria issue so much. But I would certainly risk stratify them.
Yeah. One last question, because we're running out of time. There are several in the question box, but this is a question from a nephrologist, Dr. Belamkonda Kishore. So he writes, most CKD patients develop mild to moderate anemia even in early stages. Obviously, this has a negative impact on the progression of CKD. Yet, we do not see clinical protocols to rigorously treat anemia in the primary care, as is done for the control of hypertension and diabetes. So he wants your opinion on this subject.
So in early stages of kidney disease, typically anemia is not seen unless it's due to some other cause. So if you're seeing anemia and GFR is, let's say, 65, 70, there's no good reason for the kidney disease per se to be causing anemia unless they have they are on drugs that make them insensitive to EPO. So if there's on high doses of ACE and ARBs or other drugs, you could get some degree of anemia in that setting, but other causes of anemia should be investigated if they are anemic and their kidney function is near normal or above 60. Typically, anemia sets in when GFR drops 40 or below, 45, 40 or below. So stage is 3B, late or lower stage 3A and 3B. That's the earliest usually when we see anemia, at least based on large clinical observational studies, is when the hemoglobin starts to drop. Iron deficiency, again, is the most common cause of anemia, even among those with kidney disease. You don't start treating them EPO, and guidelines for EPO use or aggressive anemia management are no longer in vogue because of the shown harm, actually, if you treat anemia very aggressively in these patients. There were observational studies and quality of life studies that suggested that you should manage anemia, but other causes should be looked for and first before thinking that it's exclusively due to the kidney disease itself.
Thank you, Rajiv. I think you have given an excellent presentation and answered a lot of questions. We have still several questions, but I encourage the physicians to contact Dr. Saran directly. We'll try to provide his email address in the chat box. So thank you once again. And
Dr. Saran, you might be able to answer them on the chat box yourself. Thank you.
Okay. Thank you very much.
If possible, if you can answer.
I'll try and do that as the session is going on. Yeah.
Thank you.
So we move on to the next topic. And the next speaker is Dr. Anupam Agarwal, who is a professor of medicine, chief of nephrology division at University of Alabama, Birmingham, and is currently also the dean of the School of Medicine at UAB. He's actually one of our past presidents of the American Society of Nephrology. We are proud to say that he is perhaps the first Indian, Indian origin physician to become the president of the American Society of Nephrology. And he is well known for his extensive, impactful research, particularly on acute kidney injury. He continues to do research even though he is Dean of the School of Medicine. So we are really fortunate to have him as a speaker. And his topic is New Perspectives on Acute Kidney Injury. Dr. Agrawal.
Thank you, Dr. Prabhakar. Really appreciate the honor to do this. Very much appreciated. So the next 40 minutes or so, I'll just share with you some new things that have occurred in this field of acute kidney injury. Y'all can see my slides, okay? Okay, thank you. These are my disclosures, none of them really relevant to the presentation that I will be doing. So really, these are my three objectives. We'll try to define the epidemiology and healthcare burden of acute kidney injury. We'll talk a little bit about major pathogenic mechanisms that underlie acute kidney injury, and then a little bit about treatment strategies, and we'll cover prevention in that area as well. So, just to give you the facts about kidney disease, you heard from Rajiv, really all the burden of chronic kidney disease. 850 million people worldwide, including 37 million Americans, have kidney disease. So that's a huge number. 37 million, so almost about 13-14% of the US population that have kidney disease. And if you look at the impact of it, it's the 8th leading cause of death in the US. 130 billion is spent on managing kidney disease, and this is just for Medicare. So it doesn't include, all the other resources that are used. 100,000 people start dialysis every year, and half of 50% of them will die, within 5 years. 9 in 10 don't know that they have kidney disease. So that's a real surprising, statistic. So it's really a silent disease that doesn't cause pain or, like cancer or a heart attack and so on. 1% of the Medicare population has kidney failure, but 7% of the budget of Medicare is spent towards kidney disease care. So really a disconnect in terms of how much money is being spent versus the population that has kidney failure. And another surprising statistic from the National Kidney Foundation, 33% of patients that initiate dialysis live in zip codes with more than 20% below the poverty line. And this is in the US. So really staggering statistics that kidney disease and the burden that it has, on our population. So let's talk about, acute kidney injury. When was this first actually described? So around 1941, there was, during World War II, the bombings of London, where they were you can see some of the pictures from that time. And during this time, it was Dr. Eric Bywaters who found a lot of people getting crushed under this rubble of these bombing concrete and so on, and found that they had significant muscle damage. And when we looked at the kidneys were swollen and red. There was like blood in the urine, or what proposed to be heme, pigment in the urine. And that's when he described the syndrome of crush injury. And that was the first description of acute kidney injury. And since then, we made a lot of progress in terms of what we understand with acute kidney injury. I won't go into the details of this, but a lot of landmark work that has been done by my close friend and colleague, Ravi Mehta, who's a nephrologist at UCSD, who trained at PGI in Chandigarh, has done a lot of work in trying to better understand and really change the terminology. Acute renal failure, just like we used to use chronic renal failure, as you heard from Rajiv, it's now chronic kidney disease. So the shift to acute kidney injury occurred by a group called the Acute Kidney Injury Network. And they have made attempts to classify acute kidney injury. And most recently, the classification we use is what's called KDIGO, and that's Kidney Disease Improving Global Outcomes. And this is their classification. Stage 1 is an increase in creatinine within 24 hours of 50 to 99% over baseline, or a drop in urine output by about 0.5 ml per kilo body weight per hour for more than 6 hours. So sometimes the creatinine may not change, but a drop in urine output in a patient in the ICU who has a catheter, you could predict, hey, in 6 hours, if the urine output has dropped, there is high risk that the creatinine would increase subsequently. Stage 2 is 100 to 199% increase from baseline within 7 days, and stage 3 is more than 200% increase, or the need for renal replacement therapy. So this classification is the most accepted one now for clinical care and also for research purposes. So why AKI? Why is this important? And why is there so much emphasis by the National Kidney Foundation, the American Society of Nephrology on acute kidney injury? That is significant implications on how we manage our patients. If you have acute kidney injury, it'll increase your length of stay in the hospital. And you know that increasing length of stay reduces payment, from insurance companies for your patients. If you have kidney failure, AKI, your healthcare utilization will go up almost fivefold, from approximately 5 billion to like 25 billion. And God forbid that you need dialysis. If you need dialysis, the cost increases almost fourfold, per hospitalization, per patient. And this just shows you the death rate per year. If you combine prostate cancer, breast cancer, heart failure, and diabetes, and if you combine all of them, even that doesn't equal the death rate from acute kidney injury per year in a large, patient population. We saw this in COVID, all multiple surges of COVID over the last 3 years of the pandemic, significant kidney involvement with COVID. In fact, after the lung, the kidney is the second most common organ involved in COVID. And actually the ACE2, which is considered the receptor for COVID, SARS-CoV-2, is abundant, in the proximal tubule of the kidney and other cell types as well. And that's the reason why the kidney is so susceptible to COVID. Some very nice work that was done by Girish Nadkarni, another fellow nephrologist of Indian origin, doing really seminal work from Mount Sinai in New York. So he was the first to really show that there was a lot of acute kidney injury in patients who were hospitalized with COVID. The initial results that were coming out from China and so on, they said, oh, no, it's just a flu-like syndrome, kidney is not involved. But as the pandemic started moving to Europe and the East Coast in the United States, it became very clear that AKI was a huge issue in the early phases of the pandemic. And this just shows you, Girish looked at 5 Mount Sinai hospitals in New York, about 4,000 patients. About 45% of them developed AKI. Half of those needed dialysis. And if you had AKI and if you had COVID, half of them died. That was really a staggering, statistic as well. And this just shows you that if you have AKI with COVID and you're in the hospital, the survival rate is half, compared to if you did not have AKI in the setting of COVID in the critical care. And, nephrologists were very busy during the COVID pandemic. I'll tell you, our hospital, even though we shut down our hospital to half capacity to try and accommodate those patients, our service, our productivity increased substantially. And you can see this was data from another New York hospital where they actually looked at it. In the purple line is the daily hospital admissions, pre-COVID. And you can see during the week, 2019 in purple. And in 2020, you can see clearly that the admissions, clearly dropped. But what happened to the nephrology consultations during that time? Even though the admissions dropped, the consultations increased significantly. The need for dialysis increased like fourfold, during this time, and really with continuous renal replacement therapy, which is largely reserved for patients in the ICU. And I'll talk about that, when we talk about management of these patients. So huge burden of kidney disease that we saw during COVID as well. Previously it was thought that if you have AKI, you would get that insult and you would recover. So that top light green line, that, you would go home. But as in the last few decades, we've seen that there's high chance that you'll get chronic kidney disease if you have AKI. And if you have chronic kidney disease, very likely that you're susceptible to acute kidney injury. But what's even more scary is 10 to 12% will never recover from acute kidney injury, and they'll end up with end-stage kidney disease, needing dialysis long-term, or maybe even a transplant. Probably related to the great technology that we have, the great medications we have, that we can keep our patients much longer. They can survive in the intensive care unit, but with the complication of, AKI or even CKD due to that AKI being a complication. So we're seeing a lot more patients now who are discharged and have AKI. I'll talk a little bit about how important it is to manage that population of patients. This is a study just to show you that risk of chronic kidney disease after AKI. So you can see all these patients, excuse me, let me grab a water. So all these patients, more than 500,000, had GFRs more than 45 before they were hospitalized. So if they had no AKI, no issues, just the general trend of the population in developing chronic kidney disease or end-stage kidney disease. But the ones that had AKI, several of them ended up with end-stage kidney disease in this huge population of 500,000 patients that had relatively preserved GFR before they were hospitalized. The same thing you can see with COVID. We know what long COVID is. So this is work from Ziad Al-Ali from St. Louis University, where he did some elegant work where if you were hospitalized, and that's in the green line, or if you're in the ICU in the orange line, you can see the risk of developing long COVID in terms of some evidence of kidney disease, proteinuria, abnormal creatinine, high blood pressure, and so on, was significantly higher. Even, this is months after discharge, after acute COVID in these patients. And you can just see the hazard ratio. If you're not hospitalized, it's 1.8. If you're hospitalized with no AKI, relative, it's about 2.6. And then if you're hospitalized with AKI, it's almost 9-fold increased hazard ratio of getting long COVID from this syndrome. So the most common form of AKI that we see in the hospital, particularly in the critical care units, is associated with sepsis. And again, very nice work from Mount Sinai. They looked at not all sepsis is the same, and not all sepsis AKI is the same. So they looked at EHR data from ICUs from multiple tertiary care hospitals, and just by looking at the chart and the medical record, they did artificial intelligence, deep learning techniques that they used, looked at comorbidities, basic labs, and vital signs, and they found that the sepsis AKI patients actually clustered into 3 different phenotypes. Again, a large population, 4,000 patients, 1,400 phenotype 1, about almost 2,000 phenotype 2, and about 600 phenotype 3. And you can see the distribution, beautifully distributed, in the blue and the orange and the green, 3 distinct subphenotypes of these patients. And what they found was these phenotypes had important prediction, whether you needed dialysis or whether you died. So in the gray bar, the subphenotype 1 had the lowest chance of needing dialysis, mortality rate of 20-25%. But if you were subphenotype 3, almost 25% you would need dialysis, and almost 50% you would die. So clearly, if you were going to do a clinical trial or have prevention or treatment measures, it's important to understand what phenotype your patient would be in. And again, this is based on very clinical data that is available in the electronic medical record. So they've now developed electronic alerts using their electronic health record, where you can categorize your patient, where do they belong, and then accordingly institute treatment measures for these patients. We'll talk a little bit about biomarkers. You heard from Rajiv about the issues with creatinine and eGFR and so on. There's been a lot of work by Prasad Devarajan at Cincinnati and others, where they found multiple biomarkers that could predict AKI much before your change in creatinine could occur. And the nice thing about these biomarkers, it can tell you where in the kidney the damage occurs. There are proximal tubule specific markers, there are glomerular specific markers, distal tubules, collecting duct, loop of Henle, and so on. So it's a nice way to say, well, if this marker is increased, you likely have injury to this part of your kidney. More recent marker developed by Jochen Reiser and his colleagues is soluble urokinase receptor. So what is this receptor, SUPAR? It's a circulating form of a protein, very low levels normally, and it's produced by endothelial cells and podocytes, but very strong prediction previously known in progressive kidney disease for like focal segmental glomerulosclerosis and so on. But what they found in this work, it was published in the New England Journal, that this marker, SUPAR, was a high predictor of acute kidney injury. You can see here whether it was an unmodified levels, whether you included some variables or multiple variables in the model 1, 2, and 3, irrespective of that, higher levels of SUPAR, shown in the darker blue, you're higher risk of getting acute kidney injury. And these were patients after a simple coronary angiogram, no major cardiac procedure or anything in these patients. So clearly much higher incidence of this marker being a predictor of acute kidney injury in a patient that otherwise did not have sepsis or any major surgical procedure. There are a lot of work in these biomarkers. So just in the interest of time, I just shared one particular example. I won't go into too much details in terms of pathogenesis, but just highlight two key areas. This is a talk in and of itself, but has a lot of clinical relevance, and I'll allude to that in a little bit. So we'll talk about mitochondria, and we'll talk about immune mechanisms. So the mitochondria, like after the heart, the kidney has the most number of mitochondria. So it's energetically very active. There's a lot of ATP requiring transporters in the kidney, and therefore there's a lot of mitochondria in the kidney. And they have a critical function. They're very rapidly dividing cells. So this recent work from David Sheikh Ahmad at Baylor showed that this protein megalin will actually shuttle molecules from the cell surface to the mitochondria. And he found a pathway that if you could block this pathway, you could actually have an outcome in terms of how acute kidney injury would develop or not develop. There's a lot of work on inflammation in acute kidney injury. So this is just some work. If you just take a kidney and look at all the cell types after AKI in an animal model, you can see there are a lot of neutrophils. This is shown in yellow with a marker called GR1. Few more B cells, T cells, and also in the blue there, macrophages. A lot of macrophages that increase within the kidney after acute kidney injury. And these are a picture just to show you that in the basal state, this is without any injury, they've used a green fluorescent marker to mark all the macrophages, and a cross-section of the kidney, you can see there's a ton of macrophages, within the kidney. And this is just to show you a higher magnification, how these macrophages have these dendrite-like processes that kind of overlap these proximal tubule cells in the orange. So these cells, there's some overlap between dendritic cells and macrophages, and they play a very critical role in acute kidney injury. A lot of work in the past that if you deplete them before injury, you actually decrease injury. But if you deplete them after injury, it makes injury worse. It actually delays if you recover. So something really did not make sense. And it turns out that that's because there are different types of macrophages within the kidney. Obviously previously there was what was thought M1 and M2 macrophages, or infiltrating macrophages and resident macrophages. But even within those, there are very distinct subphenotypes that actually have a good effect or a bad effect. And trying to understand what those subpopulations do is really critical, and work using single cell RNA sequencing has enabled us to identify these subpopulations. And one subpopulation is a specific subpopulation expressing this protein called CD46. And if you actually take these macrophages out, you can actually protect in animal models from acute kidney injury. So the feeling is that if you can target therapies to this macrophage population, you can actually protect against acute kidney injury. Yes, this is all laboratory based right now, but you can see the implications of therapies by targeting and our understanding of better markers for these different subpopulations of macrophages. We'll talk a little bit about, I showed you this graph before, why does AKI lead to CKD? It turns out there are mechanistic bases of why that would occur. And shown here is a graphical abstract from work that was done over last 3 to 5 years, showing that in the normal kidney, you have pericytes that kind of support the endothelial cell. And after acute kidney injury, these pericytes will expand and will transform to become myofibroblasts. And those myofibroblasts will start, secreting extracellular matrix through TGF beta dependent pathways and essentially cause fibrosis. So that acute insult will cause proliferation of pericytes, and then you get that fibrotic response. And that is what we think is the basis for why you get chronic kidney disease after an acute insult. And this is similar to what would happen in the lung. If you have acute lung injury, potentially could get interstitial lung disease down the road, and similar mechanisms have been postulated in other organ systems as well. Recent beautiful work, again, a lot of paradigms that we see in acute kidney injury from sepsis actually occurs in SARS-CoV-2 COVID as well. So in this nice paper, it's published in Cell, they showed that SARS-CoV-2 directly infects the human kidney, and actually that acute infection causes subsequent fibrosis, within the kidney. So what they did was actually looked at patients, autopsy, kidney biopsies, and looked at the degree of fibrosis compared to somebody with just ARDS, and significantly higher amount of fibrosis within the kidney. And they took these human kidney cells and made organoids. So these are like mini organs, and infected those organs directly with SARS-CoV-2 virus, and showed that that virus could actually enter those organoids and start multiplying and make RNA. And if they blocked RNA replication using a protease inhibitor, you could actually reduce injury and fibrosis in these organoids. So again, showing one, COVID-19 can directly infect human kidney, and two, and this would explain the basis of long COVID and the proteinuria and the kidney failure that patients with acute COVID would end up getting down the road. If you look at sepsis, again, I said sepsis is like the most common reason why you get acute kidney injury. And what's the mechanistic basis for that? This was work by Pierre Dagger from Indiana University, but he showed that using an animal model of sepsis, and he looked at the translational machinery within the kidney. You can see at time zero, there are a lot of proteins that are being translated and being made. So each of these red dots is a protein. But at 16 hours, you can see here, there's a lot less proteins that are being made. And he found a pathway called EI2 alpha that was involved in this protein shutdown, that if you block that using an inhibitor, you could actually rescue these animals from getting acute kidney injury in the setting of sepsis. So again, highlighting that trying to identify these mechanisms at the molecular level can provide insights into how we can treat acute kidney injury. And why is that important? Because if you look at what do we have for treatment strategies, a lot of therapies have been tried in animal models, and they work great in animal models. But when they go to human trials, nothing has really worked. And right now, the only FDA-approved treatment we have for acute kidney injury is dialysis. And we know dialysis is not a treatment. It is more a supportive measure till you wait for your kidneys to get better and so on. So there's a lot of excitement, though, in the field, going forward, just like what we just heard with SGLT2 inhibitors and others for chronic kidney disease. So I'll share with you some examples. So this is work from Mark Akuza's group at University of Virginia, where they looked at a non-pharmacological intervention and how that can actually have an impact in acute kidney injury. And this was a finding that they developed by serendipity. So they were doing a study where they were delivering molecules to the kidney and using ultrasound to burst the carrier of the molecule, within the kidney, so it would get delivered to the proximal tubule. And then they were doing ischemia reperfusion, and what they found in that was just the ultrasound alone. So you can see in this graph, creatinine, when you did ischemia reperfusion, the creatinine went up, but just the ultrasound alone, without those microbubbles being disrupted, caused protection. So he was like, what is happening here? And so they did some very elegant studies and found that not only was acute kidney injury reduced, but also chronic changes, fibrosis. You can see here a kidney that did not have ultrasound applied, and then with ultrasound, significantly less fibrosis, within the kidney. And subsequent work they've now found actually the mechanism. How does this actually work? There's an anti-inflammatory pathway when you apply the ultrasound, nothing to do with the kidney, really. It stimulates the vagus, the splenic nerve, which is a branch of the vagus nerve. You have a change in the catecholamines, the acetylcholine, and so on, between the T cell and the macrophages, and you have an anti-inflammatory effect, and that's how you get reduction in acute kidney injury. And more recently, they've actually looked at a detailed circuit, within the body, in the abdomen, between the spleen and the kidney, that is activated, and that's how you get protection. And hopefully we would see these. This is a non-invasive therapy that you can apply beautifully in the transplant setting, for example, activating your vagus nerve or your splenic nerve and reducing incidence of acute kidney injury. So this is just, one figure from the paper where when they applied this laser to activate the vagus nerve, and you could use any way of activating the vagus nerve, from outside externally, you could get reduction in renal failure, at least in these animal models setting. Some other work, we normally look at lactate, in the blood, right? You measure that in patients in the ICU and said, oh my goodness, patient's lactate is 10, poor outcome. So it turns out that lactate actually has protective effects. So here's a model of sepsis-induced acute kidney injury. And when you just give them saline in the middle panel, you get a lot of these vacuolated tubules and acute kidney injury. And when you give these animals lactated ringers as a form of lactate, you can actually protect against acute kidney injury. And this is just the data looking at KIM1, which is a marker of kidney injury, and then blood urea nitrogen. Clearly, you can show that lactated ringers actually is protective against acute kidney injury. And the mechanism of that was shown subsequently by Brian Reeves and Muniswamy Madesh and colleagues in this paper in Cell, where they actually looked at lactate, that it actually triggers magnesium dynamics within the mitochondria, within the kidney, and that's how it maintains cellular metabolism. There's a beautiful editorial, OMG, lactate drives magnesium mobilization within the kidney, and that's the mechanism of how this lactate actually is protective, within the kidney. So really, the surgeons, would use lactated ringers, and nephrologists would always chastise, surgeons in the ER and so on. Don't use lactated ringers because of all the potassium burden, but actually they may be a basis that it has a protective effect. So LR may actually be better than just using normal saline. Obviously you want to be careful because of the potassium content, but if someone's not hyperkalemic, it is probably okay to use lactated ringer and may have a protective effect. And this is the mechanism of how it is protective. So we'll talk about renal replacement therapy, really answer 3 questions. When should renal replacement therapy be started? What's the best modality? Should we use intermittent dialysis or should we use continuous? And what's really the dose of treatment that one should use? So there's been a lot of work done. And in terms of timing, should you do immediately? Somebody's creatinine is going up, no urine output, should we start dialysis immediately? Or should you wait for 3-4 days before they absolutely need dialysis? Again, whether standard treatment or accelerated treatment, it doesn't really matter. Beautiful paper in the New England Journal of Medicine from a few years ago. And if you started early, you had higher risk of hypotension and hypophosphatemia, and that potentially could have some adverse effects. So what I've normally recommended is, each patient has to be individualized. And this is an old paper from, Paganini from the Cleveland Clinic. So on the y-axis is survival, and on the x-axis is the ICU score, how significantly, seriously, sick that you are. So if you have low critical care scores, very good chances you'll survive, irrespective of intensive dialysis or less intensive dialysis. And if your ICU scores are really high, doesn't matter what you do, outcome is going to be poor. So it's probably in the intermediate group of patients that maybe higher and early initiation of dialysis and higher dose of dialysis may actually be better, shown here on the blue line compared to the yellow or the orange line. So that's the only caveat that, maybe that may be slightly better compared to other patients. But again, the importance that, you have to individualize your treatment for the critically ill patient. In terms of intermittent versus continuous treatment, the preference is to do continuous treatment. We use ventilation continuously. We do nutrition continuously in our ICU patients. We monitor their cardiac status continuously. So the argument is to use continuous renal replacement therapy as well, although there is no data that mortality is better, or survival is better, or the complications are better. It's easier to manage a patient in the ICU. If you have 30 patients in the ICU and all requiring dialysis, you won't have 30 nurses and 30 hemodialysis machines to do that. And CRRT is managed by nephrology, but the critical care nurse can manage it, from hour to hour. So at least it's more feasible to manage dialysis in that way. A lot of work I was telling you about, patients now are getting discharged from the hospital with acute kidney injury, and they've not recovered fully, and some of them need dialysis for a limited time, maybe for a long time as well. So a lot of work has been done to coordinate the care of patients following acute kidney injury. A patient who tells a story, publicly, so not violating any HIPAA, Marla Levy from San Francisco. She's a good friend, and she's on our, patient advisory board for our O'Brien Center. So she had acute kidney injury following cardiac surgery, and then, needed CRRT, was subsequently discharged to a dialysis unit in the Bay Area of California. And for weeks, months, she was not making much urine, and they just kept dialyzing. And then she started getting hypotensive every time on dialysis. So she came to the nephrologist and said, hey, in the dialysis units, look, I think I'm getting better. Here's 2 jugs of urine. I don't think I need to be on dialysis. Can you check my kidney function? And it was like, no, that's not good urine. You need to be on dialysis and so on. And they checked the creatinine, and actually the creatinine had gotten better. So she had recovered, but just because she was in a dialysis unit that took care of end-stage kidney disease patients, she was just being treated just like an end-stage patient. And that patient is now, off dialysis for 3-4 years with a creatinine, of, not normal, but something that she can manage without, dialysis support. So clearly we have to be cognizant of this population of patients, which is increasing significantly. Primary care doctors, rehab doctors, mental health specialists, social workers, dietitians, the outpatient dialysis and nurses. We have a responsibility to educate, the family and so on, and provide that support to these patients who get discharged, from an intensive care unit or from a hospital with acute kidney injury, whether or not they need dialysis, that they may recover. So, you don't want them to, be tied to a dialysis chair in perpetuity, and you want to monitor and look for recovery of kidney function. The NIH has actually started a big multi-center study to look at this. It's called the COPE-AKI, Caring for Outpatients After Acute Kidney Injury. We are fortunate to be a center, Vanderbilt and Pittsburgh, and there are several centers across the country that are actually studying this in great detail to come up with a criteria. And the American Society of Nephrology has created this AKI Now initiative. And part of this, there are 4-pronged strategy. One is to leverage basic science to see how we can treat AKI, education in terms of recognition and management, trying to understand new pathways that can tell us how the kidney recovers, and then really AKI recognition, in children and other populations. How can we recognize acute kidney injury quicker so we can intervene and prevent, further worsening of kidney function? And in light of that, there is another NIH study called the Kidney Precision Medicine Project, looking at human kidney disease. I told you a lot of the work in animal models has not translated to human studies. So this study, the Kidney Precision Medicine Project, is looking at human kidney disease. And what they're doing is trying to take human kidney biopsies from patients with acute kidney injury, as well as CKD, to better understand human acute kidney injury. And this is just a detailed workup They're looking at the clinical presentation. They'll do traditional and digital pathology, detailed omics, metabolomics, proteomics, transcriptomics, and imaging, and then correlate that with clinical outcomes. And the goal is to create a human kidney tissue atlas for acute kidney injury. And this would create a lot of insights. I know Michigan is part of this as well, looking at systems biology approaches. You know, the kidney has over 60 different cell types that we know of. It's not one cell type that get damaged and you get kidney failure. So to identify treatment, you have to find what cell type is damaged and then clearly dictate, therapy for that. The nice thing about this, it's the community. It's not just physicians that are involved or scientists. Patients are critical partners in the study, and they have an active voice in the entire research protocol. They actually help develop the consent for the kidney biopsies to be done in this study. So we're hoping this in the next 3 to 5 years would clearly provide great insights and advances in how we understand what acute kidney injuries as well as chronic kidney disease. So just to summarize, hopefully I've convinced you that AKI and AKI leading to CKD is a growing threat. There are a lot of subphenotypes of AKI, particularly in sepsis, and that has clinical implications in terms of how we manage those patients. A lot of biomarkers, even better than creatinine, that we can use to diagnose and prognosticate AKI. Immune mechanisms is a target for therapies, particularly macrophages, and I highlighted how important it was for post-hospital care for acute kidney injury survivors, and there's a lot of potential for future therapy and development. I'll stop here and thank you for the invitation. Really honored to speak with you and glad to take any questions.
Thank you, Dr. Agrawal. That was a very excellent presentation, and both from a mechanistic and a clinical point of view. I think while we are waiting for some questions, let me start out by asking you to comment on, you talked about the AKI to CKD, transition. So are there any reliable clinical determinants or biomarkers that indicate the chance of progression to CKD in patients who have seemingly recovered from AKI?
Yeah, I think in animal models, Dr. Prabhakar, yes, there are markers like galectin-3, and that's a marker even in heart fibrosis, for example. Right. If it goes up in the blood, it's high chance that your kidney will get fibrosed or your heart will get fibrosed after an acute injury. They've done some studies using that marker in humans as well, but in small numbers, less than 100 patients. But that's the only one that I know that in the blood, or actually even in the urine, you can measure that by a simple ELISA, and that can predict whether you'll get chronic kidney disease. So.
There's also some talk about, the role of blood pressure following AKI as a determinant of it. Would you comment on that?
Absolutely correct. Yeah, so there's a significant hemodynamic component in acute kidney injury. And if patients develop hypertension after AKI, the chances of them, whether they were predisposed to chronic kidney disease, nobody knows that, but that is another clinical predictor that maybe you would end up with chronic kidney disease down the road. So absolutely. So it's a great, clinical marker of developing chronic kidney disease.
Thank you. There is a question about, I think, post-COVID, CKD, incidence and mortality, something like that. So could you comment on that?
Yeah, I've seen some studies about APOL1 in African Americans. So just to for the non-nephrologists in the group, APOL1 gene mutations were common going back to evolution in Africans in Africa, and that actually rendered them protective from sleeping sickness caused by trypanosoma brucei. But as those Africans emigrated to the US, centuries ago, that mutation actually rendered them susceptible to chronic kidney disease. And that's why you see more kidney disease in, Black population compared to other ethnicities in the US. And now there are treatments, Vertex Pharmaceuticals actually come up with a treatment targeting APOL1 that can actually reverse or actually treat, chronic kidney disease. Great advance. Just a paper published recently in the last few weeks. I don't know if anybody has looked at APOL1 mutations and COVID and AKI per se, Dr. Kishore. So, but I'm not aware of anybody who has looked at that per se. But if you know of some, please share that. So,
Dr. Agarwal, I have a question. Even though I'm a cardiologist, nephrology, I think kidney disease is very close to my heart. And one of my family members were recently diagnosed with acute kidney injury and subsequently has to go on dialysis in India. Is more the India and the heart kidney disease has significantly increased when I finished my residency fellowship in 1991 in India versus now. At the time, the dialysis was very little and the kidney disease were very little. If you can comment about the what we are doing in US, what you guys are doing in US versus can we help India back home to see whether they can bring up the similar kind of stuff, and nephrology still seem to be little less. So can you comment about the kidney disease in India?
yeah, no, absolutely. Kidney disease in India is huge, very significant. And ironically, it's not from diabetes or, hypertension. And there is a, CKD of indeterminate origin. People think it's because of heat or, in the sugarcane plantations and so on, particularly in, southern India, in Andhra Pradesh, and Tamil Nadu, and so on. There's a huge incidence. We really don't know what the mechanism of that is yet. A lot of theories that people are postulating. They see it along the equator in Central and South America as well. So there are similarities to what they're seeing. And some of the nephrologists in India have done really great work in that regard. The problem with kidney disease in India, it's still restricted to the big cities, in terms of treatment opportunities. I grew up in Mangalore in South India. And when I left, India 30 years ago or something, there was no dialysis in my hometown. Population of a few million, right? You had to go to Bangalore or you had to go to, some big city. And I think it's a big challenge of access. So, apart from that, but the technology in the other hospitals is significantly advanced, just like the US. And I think, all the various tertiary care hospitals in India, they have the same standard of care that we have here. I don't think it's different. And because of that, you're seeing those patients survive that previously they would have died and you would not even known that they had AKI. But now you can keep them going on ventilators or whatever, and they survive longer. So you're seeing AKI, just that they need dialysis. And that's my gut feeling, Srini.
Yeah, thank you.
Thank you. So I think we just have like 3 or 4 minutes left. So we're going to conclude this Q&A session because we have concluding remarks by the president and Dr. Gangasani. So I want to thank both Dr. Agarwal and Dr. Saran for amazing, excellent presentations, very informative. And we hope to see you again sometime in the AAPI sessions. Thank you. And Dr. Kohli.
Yeah, hi, thank you so much. The tour de force of a presentation by both of the distinguished panelists. And we're so fortunate to have you as our speakers. And being a psychiatrist, just like Srini injected his question, let me ask you a question also on behalf of my patients and my profession. The lithium and the stegratol and all these things that seem to be toxic at times, and also our patients' lifestyles and adherence to treatment is kind of sketchy. So we get a lot of questions about these things. Just a brief comment, Dr. Agarwal, before I go to the next formalities.
Clearly, all those drugs, I think they're more chronic kidney disease like lithium. I mean, I'm sure you've seen patients on lithium who get both acute and chronic kidney disease. I think a lot of things that we do to our patients, clearly we need to monitor carefully. So absolutely, I think there is a role. I mean, you have to weigh the benefits and the risks.
Right.
Is that patient really critically important for their manic depressive psychosis? And, so you have to weigh the risks and benefits in that regard. So.
Right. Yeah, similar question to Dr. Saran. When you mentioned clinical care only accounts for the 20% of our outcomes, that is really a striking number. Probably that's much higher even in psychiatry, probably 100% of outcomes are social determinants. I know your emphasis on STOH was really well taken, and I think all of us, that's a take-home message, that just downstream taking care of our patients is not adequate, and we have to be the advocates for the social determinants of healthcare, especially being a psychiatrist, again, in mental health, from the equity in housing and nutrition and access to care and pharmaceuticals and advanced care. Thank you again, and let me share the screen for our virtual plaque presentations for both of you. 1 second. All right, here is our plaque, Dr. Rajesh Saran, MD, MRCP, for his outstanding contribution in the field of nephrology. We welcome you, Dr. Saran, to AAPI Distinguished Speakers Club, signed by Dr. Srini Gangasani, our CME chair for year 2022 to 23, and myself from Oak Brook, office of AAPI. And next one, Dr. Anupam Agarwal. Thank you again. We recognize you for your outstanding contributions in the field of nephrology. You're a legend, and both of you are legends. And thank you for being here. We welcome you both, and also Dr. Agarwal, as the member of AAPI Distinguished Speakers Club, again signed by Dr. Srini Gangasani and myself. And I will let Dr. Srini Gangasani finish any remarks he wants to share. Thank you.
Thank you, Ravi. And thank you, Dr. Agarwal and Dr. Saran. I think we're wonderful presentation. I learned a lot as a cardiologist. I think from acute kidney injury staging, and there is a very useful data. I think you guys presented. It's amazing. I think when you're in a cardiologist, you're in your own cocoon. I think you don't come out of nephrology as much, even though you're doing a lot of damage to the kidneys through our catheterizations and stuff. But it was very useful information. Thank you, both of you, for sharing the information. It was wonderful. And the plaques will be mailed to you. I think if you can send your address on the Dr. Prabhakar Garu or me will send the plaques to you. Thank you very much. And
I just want to do one more plug here. And our convention is coming up in Philadelphia. Please, Dr. Agarwal and Dr. Saran, please, if you're available, please let us know. And also I request all the members who joined in big numbers today to attend our convention July 6th to 9th in Philadelphia. And our registrations are picking up, and we're looking forward to a great convention with CME as well as other activities that usually go with our AAPI conventions, which are very colorful, like a Bollywood movie with everything included. Thank you, and have a safe weekend.
As I said, tomorrow we have another CME about the lifestyle medicine at 11 a.m. Eastern. It's about obesity and weight loss done by the lifestyle medicine the committee. So the first talk is by Dr. Fitch from Harvard Medical School and about obesity and what to do about the chronic maintenance. And the second talk is by Dr. Freites, who is the president of American College of Lifestyle Medicine. Both are great speakers, and looking forward to a great CME tomorrow at 11 a.m. And one housekeeping information about the CME certificates. There are some people haven't gotten the CME certificates. If you don't get it, get an email with the CME certificate to how to get it. Please email me. I'll put my my email in the chat box with sriniji@gmail.com. Thank you again. Have a great day. Have a great day.
Thank you all for the attendees for participating in the webinar. Thank you.
Thanks very much.
Thank you all.
Yeah.
Bye.
Enjoy.